Well, I hope you enjoyed that talking point segment. Before we get to the Wheel of Wounds, Sharon, I just want to tell you that you are significant, not only to me, but I know significant to the entire wound care community. You clearly define success.
Thank you. I appreciate that. That's very gracious of you.
And today you're going to have the significance on all of us by spinning. Are you ready?
One more time. Let's see what December brings.
And take it away in a nice big spin there, and around and around we go. We never know where this wheel is going to stop, do we? It looks like it's starting to slow down a little bit though, Sharon.
All right. Almost. What are we going to get to here?
It is slowing. It's slowing very...
Slowing.
Oh, we are back on venous ulcers.
Venous ulcers. Great topic, especially this month of December when we have so many people out Christmas shopping and not wearing their compression stockings when they're doing it.
Well, you know, there's a lot to be said about venous ulcers. We had an episode just recently where we started talking about the clinical aspects of venous insufficiency and the management of venous ulcers, but we're going to continue on that same theme. So if you're ready, I think I will spend a little bit more time talking about venous ulcers. All right, venous disease and venous insufficiency ulcers. For those of you that are loyal fans, you'll remember that we started talking about venous disease a few episodes ago. To spend an entire 45-minute show on venous ulcers is not appropriate, so we break it into segments, and we're going to continue talking to you about venous insufficiency and the ulcers that relate to this disease process. A reminder, the pathophysiology here is due to venous valvular damage. When these valves are injured, they begin to leak from the pressure, the hydrostatic pressure exerted on that small blood vessel. That hydrostatic pressure overcomes the osmotic pressure of the tissues and starts to fill the tissue with fluid, causing edema. This cartoon shows exactly what we're talking about here. Valves in the veins typically work in a one-way fashion. They close and open. And when they're closed, you cannot have a reflux of the venous blood flow. However, when those valves become damaged and they don't close, you can see there is an open conduit, and that venous blood pools, increasing venous hydrostatic pressure. What causes damage to venous valves? There's many things. Immobility, sedentary lifestyle, prolonged standing and sitting can certainly injure valves. We see it commonly in pregnancy, patients that are overweight, those obese patients. Smoking can contribute to the damage of these tiny, fragile veins. Probably the most common history that we get when we're sitting in the wound care clinic talking to patients about their venous insufficiency is they give us a history of having a prior deep venous thrombosis. That certainly, whether it's post-surgical or other fashions, can contribute significantly to valvular damage. And then there's other rare conditions such as hypercoagulable states, what you would see in some of our cancer patients that can injure valves. But there are many things that need to be explored when you're discerning what could possibly be the etiology here. We need to talk a little bit about the calf muscle pump and how important calf muscle pump is to venous return. When you have movement, flexion of the foot, contraction of the calf muscle, that squeezes the deep system, forcing blood back to the heart. Again, when that muscle activity is relaxed, the valves close, preventing reflux. That negative pressure that is now in that valve pulls venous flow from the superficial system through the perforator veins, and the system then repeats. Another muscle contraction, again, forces blood flow back to the heart. We can also have problems for venous insufficiency when the calf muscle system doesn't work, but you need that compression, that constant muscle compression to squeeze these veins to force that blood flow back to the heart. We've talked about the clinical features of venous insufficiency: swelling from edema, the hyperpigmentation that is often seen from venous staining, and then frank ulcerations in the worst cases. You've seen them commonly, you know what they are. Here are some photos to reflect that, your memory. How do we treat them? Well, we compress. If it's a failure of the venous system or failure of the venous muscle pump, we can help that by adding extrinsic compression to force and help return that blood flow. Don't forget that in addition to the mainstay treatment for venous ulcer, which is compression, is that we need to do a good job of vascular evaluation and intervention in some cases whenever possible. Let's look to the literature and see what it says about compression therapy. This is a Cochrane collaboration review looking at compression for venous insufficiency ulcers. A very nice review looking at everyday common modalities for treating venous disease. What were the conclusions of this publication? Well, the Cochrane database concluded, looking at compression therapy, various compressions for venous leg ulcers, that compression increases the ulcer healing rates when compared with no compression. They also discovered through this review that multi-component systems are much more effective and efficient in managing this disease than single-component systems. And finally, those multi-system component bandages that contained an elastic component were again more effective than those multi-system dressings that did not contain inelastic components and constituents. The Cochrane database also looks at intermittent pneumatic compression therapy for the treatment of venous disease, such as our friends from Spectrum, the devices that they deploy in the home setting. What did the Cochrane database conclude here? Well, intermittent pneumatic compression therapy for venous leg ulcers may increase the healing compared with no compression, but there was some uncertainty as whether it increases the healing when added to the dressing management, it was complementary or not. There was some issues there to determine whether or not there was a synergistic effect. Clinically, we see that synergy, but the data doesn't quite prove that yet. Also, rapid intermittent pneumatic compression was much better for healing than in slow compression cycles. But clearly, based on the data, which is again just beginning to populate the literature, further trials are clearly needed to feather out some of these additional areas. If you look outside of the Cochrane database to literature, this is a very recent publication published in the Journal of Vascular Surgery in 2011 that looked at intermittent pneumatic compression, the physiological and clinical basis to improve the management of venous leg ulcers. Very nice paper done by Dr. Camerata. What did they conclude? Well, with the application of intermittent pneumatic compression, and when this was applied in combination with sustained graduated compression therapy, they found that it improves the outcome in patients, especially those patients with advanced venous disease, which is really where this technology should be used. Should not be a mainstay first-line therapy, but a complementary therapy used in those very refractory, those difficult to heal patients. What's very interesting is CMS, Medicare, has also adopted this stance. If you go to the website, you will find this information. Our current policy covers the use of pneumatic compression pumps for patients with refractory edema from chronic venous insufficiency, those with significant ulceration of the lower extremities, and in those patients that have received standard therapy but have failed to heal over 6 months of continued treatment. So once again, Medicare has adopted the stance, similar to what was found by Dr. Camerata and others, that these pneumatic compression devices can be very helpful as adjunct therapies, but should be utilized in those patients that are difficult to heal and that fail standard therapy. I think that just makes sense. So I hope you've enjoyed this little summary of the use of compression in patients with venous insufficiency ulcers. Hopefully it will complement your clinical practice.